and Instagram and
I'm not now. I'm just on, we're just doing Facebook right now.
Okay.
Okay. So I think we're live. Welcome, everyone. This is Fertility Talks. I'm best-selling author, Pathways to Pregnancy, and I'm the director of one of North America's leading wellness clinics called Alive Holistic Health Clinic. I'm an acupuncturist, fertility strategist, and I am super thrilled because we have Dr. Nayat again, and we had him speak. Let me look here. He spoke. If you go to @Meet Mary Wong on YouTube, you're gonna find our last post together, and that was number 1. Let me see, 78 on how to help implantation, and we were talking about non-invasive endometrial receptivity and specifically endometrial compaction. So if you want to check that out, go binge watch. I've got a gazillion videos. So, but today we're going to talk about chromosomal testing, which is specifically PGT-A, the pros and cons for IVF. And so what PGT-A is actually, you know what, Dr. Dan Nayat, thank you for being here. And let's just, add you in for so that you can contribute right away into this conversation.
Yeah, so thanks again, Mary, for having me. Last time was really fun, so I think we both really wanted to do this again. We found some time. Funny enough, last time we spoke about the endometrium receptivity and a different approach to looking at it, which I sort of call the soil, and now I guess we're talking about the seed, because you need a combination of both to make it all happen.
Totally.
So PGT-A, we used to call it PGS, Preimplantation Genetic Screening, and we're getting a little bit more sophisticated and we're calling it PGT-A, which just means Preimplantation Genetic Testing. The A stands for Aneuploidy, which means we're checking chromosomes. There's PGT-M, which is the same sort of steps, but instead of the full chromosomes, you're checking specific genes. But the concept of PGT-A is that we know to be a healthy live birth, you need 46 chromosomes. I mean, there are examples of live birth like Down syndrome where there's an extra chromosome, but as a general rule, we think many, many embryos don't make their way all the way to a successful pregnancy because the chromosomes are off. So if you're off from 46, whether that's not enough, so less than 46 or too much, above 46, we think that's not compatible with a healthy live pregnancy. Now, a few things on that topic. One, visually, of course, we have a grading system. So, anyone's ever gone through this and never had an embryo transfer, we always talk about scoring your eggs. It's a 4AA, it's a 2BB, it's a 4CC, whatnot. Yes, the grading system is correlated with success, but everybody will tell you that, oh, I had a bad looking embryo and look at my beautiful child, or that, the doctor told me it was the best embryo they ever saw. It didn't go anywhere from there. So the visual testing is pretty good, but now we have an ability to analyze those chromosomes. So the way we do it now, or the current standard of care, is we call it invasive in the sense we wait till day 5 or day 6 for what's called a blastocyst. So at that point, it's hundreds of cells. I guess you can think of it maybe like a blackberry or a raspberry. So lots of little cells on the outside. That's called the trophectoderm.
I love the blackberry. I've never given the terminology as a blackberry. It's a good...
I think it kind of looks like it too if you look at the pictures. And so what we do now is we can take a few cells out. It's something that's pretty routine and standard, but obviously you need a very talented embryologist to do that. And they can take a few cells out and we can analyze it. So the simplified version, and we're going to get deeper into the pros and cons, is, if you can take a few cells and analyze it, and if the chromosomes are not 46, so abnormal, hey, that's an embryo that wouldn't have resulted in a healthy pregnancy. And if the chromosomes are 46, great news, this has a pretty good chance of success. That's the very simplified version of things. So maybe I'll stop there and we'll take it from there.
Well, I mean, okay, so you hit on something that is key, right? So it's like you can get genetic testing, and actually I want you to tell, or I'll ask you, is CCS, comprehensive chromosome screening, the exact same thing?
Yeah, it's just another term. It essentially means we're taking a few cells and we're checking all the chromosomes. So we have 23 pairs of chromosomes. So 23 times 2 is 46.
Yes. And so, the thing is, how I always see is like the higher the stakes, meaning the more intervention we do, the higher the expectation. And although we're talking about this and speaking to this, what we know is that it's still not 100%, even when you get that tested, right?
Not only is it not 100%, it's far from 100%.
Exactly. So and that's why I think it's so relevant to speak to this. So thank you for saying that.
Yeah.
And so really, like, I love it that you're saying, okay, well then let's look at the pros and cons and let's see if it serves you versus everybody should be doing it.
Yes. Okay. So first of all, I have full disclosure. I don't have an incentive. I'm not here to tell everyone to do PGT-A or no one to do PGT-A. And of course, this is not medical advice because the details of your case are extremely important. But I'm just going to highlight things to think about, which probably will lead you more confused as you started because now there's so many more variables to consider. So probably if you're looking for a decision, I probably made you more confused. Okay. Let's talk about the pros. Okay. So as the theory stands, so obviously you need 46 chromosomes to be an embryo. And let's say you have multiple embryos. We sort of see it as a gradient. If that embryo has multiple chromosomal abnormalities, it's probably something that's just not even going to implant. Okay. It's still obviously heartbreaking, but it's not going to implant. You're going to put it in and 2 weeks later have a negative test. Okay. And we're always going to wonder, why was that? Was it the seed? Was it the soil? Did I not have enough progesterone? Is my thyroid off? Did I exercise too much after the transfer? But really, if that chromosome is abnormal, there's nothing you could have done to have changed those outcomes. Okay. So on the pro side is if you can deselect, so let's say you have 8 embryos and 1 of them is normal and 7 are abnormals. Well, at least now you've saved yourself a whole bunch of transfers that weren't going to work, and you can get to that finish line faster. That's the theory behind it.
Right. But okay, so here's the thing. So in the news and, in the past, and I don't know how misleading it is, they'll say, oh, so for example, Dr. Gleicher, I might as well name him. And I interviewed him in the past as well. So if you guys want to check that out, but there's cases that have been cited where they say, oh, it's abnormal, but I don't know if it's really abnormal. Is it actually mosaic that they put in, right?
Okay. So you're going to the con side. Okay. Let's stick with the pro. So the pro in theory is let's do a thought experiment. Let's say it's 100% perfect test, and whatever the result is, it's what truly it is. So if you had this 100% accurate test to say if these chromosomes are normal or not, then in theory, you can 100% be sure that these embryos you screen had no chance, and these are the only ones that had a chance, but still doesn't guarantee you outcome. So we sort of talk about having 46 chromosome is a prerequisite, but not the only thing. So you need 46 chromosomes, but there's other variables going on, right? You put that in the non-receptive endometrium in the wrong soil, and that embryo isn't going to work. Okay.
Right.
So in theory, if it's a 100% accurate test, for sure you would have gone into the finish line faster. So if you had 6 embryo and none of them are normal, and this was a 100% accurate test, then you would have saved yourself a year's heartaches of failed transfers so that you can go ahead and make new embryos and go on with the next test.
So I'm going to add in here because this is a reality when you say save yourself years of distress, and because I was that person. I was in the time when there was really no PGT-A available. So I literally went from cycle to cycle and you just put them all in blindly. So I literally, attempted 8 IVFs.
Well,
FYI. And without, gosh, like wouldn't it have been much better if I could have done a whack of retrievals and then tested and then maybe have seen that maybe some of them were actually viable and whatever, right? But anyway.
So in a thought experiment of it being a perfect test, you will identify the only embryo that has a chance and save yourself the heartache of the ones that really have no chance. You just couldn't tell visually. Okay. Now, let's go to the spectrum, which I started talking about a minute ago. Very abnormal embryo, not even going to continue to grow, not going to implant. Perfectly normal embryo in theory, healthy pregnancy. Somewhere in between, it could implant and be a miscarriage. So most of the data shows us now that most miscarriages are in fact from abnormal chromosomes. And a side interesting thing is a general rule the embryos that can make it to implantation and stop usually represents above 46 chromosomes. So you have everything you need, but you got too much, as opposed to not enough. So most of the time, if you test your miscarriage to find out if it's a chromosomal issue, you'll usually find what's called trisomies. You have an extra chromosome. Of course, it's not always, but that's the golden rule. Okay. So in theory, PGT-A, if it was perfect, would do two things: get you pregnant faster. This is the only embryo that has a chance, and keep you pregnant, because an embryo that's, an extra chromosome, pick your extra chromosome, maybe you'll get pregnant, but then you'll miscarry.
Right.
Okay. So the best case scenario is you did PGT-A, get you pregnant faster and keeps you pregnant. So increased pregnancy rate and decreases miscarriage rate. And I'm going to pause there because I think it's really important when we talk about success rates. I think maybe we spoke about this last time, but it really depends how you define your success rate. If you define it by your chance of a baby per embryo transfer, then all the studies will show you PGT-A is as good, if not better, because you've already screened the embryo. But if you define it as the chance of a baby from starting the cycle, it does not increase your pregnancy rate. That might sound a little bit confusing, so I'm going to explain it a little bit. I'm actually going to table that and go into the cons, and then I'll put it all together.
Perfect.
Okay. But any questions about the pro side?
Well, maybe you need to explain exactly what the trophectoderm is.
Right. Okay. So blastocysts, think of this raspberry. The outside part that we can see is called the trophectoderm. So this is what eventually becomes the placenta. Okay. Now the inner cell mass, which you can't see, it's on the inside, becomes the baby. Okay. As you can imagine, just technically speaking, we're biopsying the outside. So this is the trophectoderm, what would have been placenta, or what would develop the placenta. Okay. So here's the cons. So one, we know that no test is perfect. It's just a test. It's not God saying this is for sure what's happening. It's a test. Okay. And when you say it's not perfect, what can go wrong? So maybe the analysis of the cells is incorrect, but the technology these days is so good that most of us believe that the result you see is truly the result. But what we don't know is a few things. Maybe it's a sampling error. Maybe these 5 cells was a pocket of bad cells, but it doesn't represent the entire embryo. You can't biopsy the whole embryo, or else you have nothing to put back in. Okay, maybe this represents the placenta, but not the actual baby, the inner cell mass. So some interesting parts on that. There are people, or there are researchers who are saying maybe we should be actually biopsying somehow the inner cell mass. So there's some interesting research on that. Maybe
So wait a second. So no one's done that though, right? Because that's quite controversial.
Right. I mean, there are basic science studies on it. So these are embryos that aren't being put back. Or there are studies on, like, if you have an abnormal embryo, take the embryo that you would have discarded, cut it into pieces, and see if you get the same results. And are they congruent or not? So that's the controversial part to it. The controversial part that's getting a lot of airtime in the last year or two is what we call mosaics.
Yes.
Okay. So think about us sampling 5 cells, okay? And if all 5 cells said extra chromosome 19, then we say this whole sample is an extra chromosome 19, and we think that represents the whole embryo. If all 5 cells said these are 46 chromosomes, we represent it as normal, okay? But what if 4 out of 5 said normal and 1 out of 5 didn't? So, probably up to 2 years ago, we had like a cutoff. So if 4 out of 5 were normal, we still consider that normal. If 1 out of 5 was normal, then we would consider it abnormal. But nowadays we're reporting it. We call it mosaic. We say, you know what? It's not 100% normal. The 5 cells, it's not 100% abnormal. It's somewhere in between. And we call it low level and high level. High level means majority abnormal, but some normal. And low level means majority normal, but some abnormal. And we sort of see, we're learning, right? This is a ongoing data finding process, but we're finding that what we used to think is like, if there's any abnormal cells, it can never work. We're noticing that it can certainly work. It's just the efficiency goes down. The pregnancy rates are lower, the miscarriage rates are higher, but it doesn't mean it can't work, okay? Okay, so one issue is that we're biopsying not the entire cell. right? It's a sample. The other issue is we're actually biopsying what will be the placenta, not the actual baby. And also, we don't always get consistent results. Okay. Now, I'm going to add to my cons list, okay? And just because there's more cons than pros doesn't mean con wins. Of course, you can add price to the con.
Yes.
And I think it's a con because I always sort of say everyone has a limited amount of resources, time, money, stress. And once you hit your wall, you're not trying again. And if you don't try again, you're not going to reach the finish line. So I consider money as a con for sure. Now here's the controversial part, because you can make an argument for both sides. So by definition, no test can be 100% accurate, correct?
Right.
Even if it's close, it's not 100%. So it means there's certainly some embryos that we probably discard that who would have known what would have happened, right? There must be some embryos by definition that we said we're never transferring this that maybe could have. Okay? I'm not saying a lot of them, but okay. So, and the other important part to that is us doing genetic screening does not change the embryo. I'm not doing CPR on the embryo. I can't turn a bad embryo into a good embryo just because it's a genetic screening. I'm just revealing what we think will happen. Okay. So if you look at it like by cycle start, so this is where the success rate confusion comes. If you look at it by cycle start, PGT-A does not improve your pregnancy rate because it doesn't change your embryos. Whatever will happen, right?
Right.
So if you have 4 embryos and you don't test them and you put one at a time, eventually you'll find out if you're 0 for 4 or if there's a good one. If you test them and they're all abnormal and you put them away or you discard them, you never even put an embryo in, you're at 0%. So because it doesn't change the embryo and it by definition throws some away and it's not perfect, then by cycle start, it actually lowers your pregnancy rate. Does that make sense or is that confusing?
Interesting. Well, it's a little confusing, but to the, I think for other people just listening to this, but I get what you're saying for sure, right? Because it's like, you can't change what's there. You're just testing it.
Exactly. So, you know, I won't comment on Norbert's comments because I didn't see what he said, but he's known to work with a different patient population, which are maybe older.
Yes.
And so by that definition, they have less embryos and less screening. So he says, you know, but if you don't put it in, you don't have an opportunity, which, because by some definition, some of those embryos would have worked. So the way I put it together, and that's just my own way, again, it really depends on the case, but in general, if you have a patient who's only going to do one IVF cycle for whatever reason, finances, stress, pick your reason, but they say to you, we got one IVF cycle in us, then I generally say, don't do PGT-A. Whatever number of embryos you have, we'll eventually put it in one by one, and hopefully we're going to be successful along the way. But if we do PGT-A, we're going to discard some embryos, and if you didn't succeed, we're always going to stay up at night and say, what could have happened? Right?
So this is interesting that you say, you know, when you don't test, you'll still do one by one.
Well,
but
it depends on the scenario.
Okay, all right.
It depends on the scenario. I'm talking in generality.
Okay, fine. Okay.
If I have a couple whose focus is, I'm going to get there, I'm going to keep trying till I have to, like I'm goal oriented and I just want to get there faster with less stress and less craziness. And I say, okay, well, if we're using it as a form of efficiency, then I would use PGT-A rather than doing, 8 embryos, even if you want to do 2 at a time. So 4 transfers. I don't know. What if none of those 8 embryos are good? Let's find out. Let's screen. So me personally, I'm not going to speak on every other physician. I use PGT-A as a form of efficiency, but if they have 1 embryo in them, I don't generally, if they have 1 cycle in them and that's it, I generally don't. Of course, that's general. If it's a patient who has 1 cycle in them, but we think is going to get 16 embryos, yeah, that's a good way to select.
Right. And so then let's tell everyone how many typically is in that sample size to test, right? So, because if you're going to have 1 embryo, is it really a good idea to test versus 20? So what is typically the batch size?
I just want to make a comment that that's where the clinical story really depends. So if you see a couple and she's had a miscarriage, which is traumatic, and you find out that was from a chromosomal abnormal embryo, here's someone who's happier to test that embryo and save herself that craziness she went through
Yes.
than not. If it's someone, so that specific situation where, you know, you might say, hey, with one embryo, I wouldn't do it. But in her case, you know, you better believe she's pretty. She'd rather fail, you know, the way we talk about it, she would rather fail at the embryo level than at the pregnancy level.
Right. I never quite looked at it that way, but that's a good point, because of course, if you don't test and you just put it in, there's a chance that she'll just miscarry again. But I have witnessed a couple of cases where it's chromosomally normally tested and they both ended up in a miscarriage. So I thought that was interesting.
Like, which is a point we said at the beginning, it's not the only thing you need, but it's a prerequisite. You for sure need 46 chromosomes, but there are other factors going on.
Well, but then I'm not 100% sure though, if it's still really, as you say, the soil versus the seed, right? Because now I can actually go back, because this woman had, she did chromosomal testing, put in normal embryos. Some of them didn't work. And then one actually became a miscarriage. She ran out of embryos and she said, screw this, I'm just going to do it. And she ended up doing day 3, not tested, a fresh transfer. And in her case, it was more of a fresh transfer thing. Or maybe that is the environment then, right? Because maybe her body does better on a day 3. I don't know.
I think that's what makes us as physicians like crazy plus passionate about what we do, is because there's so many unknown variables. There's so much for us to figure out.
So then with that unknown variable, any thoughts on impact of actually biopsying the cells?
Yeah. So yeah, actually that's a great segue. So when this first started, you know, before I was even learning about fertility, so I don't want to be a historian who didn't live it, but the way the story is told is 2 parts. We used to do a very, very basic kind of chromosome testing called FISH, where you literally almost splatter the chromosome on a slide and you color code it and you say, okay, 2 yellows, so that's a pair, and 2 reds, and that's a pair, and 2 purples, and that's a pair. And you would only check, you know, 3 or 5 sets of chromosomes, not 23. So the technology is super advanced compared to what it was. But we also used to do it on day 3. And if you remember your pictures of a day 3 embryo, it looks like, I don't have another fruit analogy, but it looks
I'm like, it's not a fruit, it's only 8 cells.
no, it's like 8 cells. And so even though these are like what we call multipotent cells, so they're not yet defined, they can turn into anything. If you take 1 or 2 cells out of 8 cells, it's probably more harmful compared to taking a few outer cells and something that's hundreds of cells. And so that's what we found is at the beginning, you know, eventually they noticed that, hey, there's actual harm of taking 2 cells out on day 3.
Yes.
We think that's less harmful on day 5, but still there's human error, there's fragile embryos, so we can't say that it's 0. Okay, so we can't say, so it's still called invasive, which is a good segue, because what is really hot in the industry now, so everybody still likes PGT-A, although there's pros and cons, but maybe we can go away from the invasiveness part of it. Maybe we do what's called non-invasive. There's sort of 2 approaches to that. Some people are trying to, so when we think of a blastocyst, I think of a balloon. There's a lot of cells on the outside. On the inside, it's almost a fluid cavity. And then on one part, there's an intercell mass. So some people are trying to sort of needle biopsy inside where the fluid is, the blastocele, and say, okay, what if we analyze this fluid? Maybe that is less harmful and more information because it represents almost the debris from all the cells. And some people are actually trying to analyze the culture media, what is discarded from the embryo. This is a bad analogy, but it's kind of like you could probably tell a lot about someone's house by going through their garbage. You could see what's outside, what they throw out and stuff like that.
Yeah.
I mean, each of that, we all think the non-invasive PGT-A is the next thing that will happen, but of course it will come with its own pros and cons.
Is anyone doing that right now?
Yeah, there's definitely
like in Canada.
Yeah, I mean, there's definitely people actively doing in studies. Is anybody using it clinically? I can't say that I know for sure. but I know there's people that are pretty close. They're like testing it in clinic to make sure they're comfortable with the technology.
And what do you think of it?
I think it makes a lot of sense. I think it makes a lot of sense, but it's still, to me, you know, it still adds the pros and cons don't change, because by definition, it's not a perfect test. And I think I would still, you know, if you told me the non-invasive and invasive were the same accuracy, I would say, well, then I'll pick the non-invasive, please.
Sure.
If you said to me the non-invasive is an extra X $1,000, then I'd probably sit there and say, is that really worth it? If you said to me, yeah, but I still think it's because by definition, it won't be a perfect test because it's just a test. No matter how good it is, it's not for everybody. I would still probably use it as a efficiency selection tool.
Right. So, I mean, it's interesting that you say, you know, it may increase efficiency, and yet, you know, I'm thinking specific, of course, I'm just using specific case studies now, right? So a woman comes in, she's had 4 miscarriages, and then before she came to see me, she did a round of IVF, and she actually had 4 chromosomally normal tested embryos. And then, so she goes one by one, and sure enough, she didn't get pregnant first round, didn't get pregnant second round, third round, she got pregnant, miscarried, and then she had her last embryo. So really, in the end, it became...
Tell me it's a happy ending. What happened?
It was a happy ending, absolutely. Absolutely. But out of 4 chromosomally normal, the last one was the baby.
So again, I don't like to comment on things I don't know the details, but I can predict that they probably changed things along the way. Like they must have made some changes in the protocol or how they're transferring or support, I assume, but again, I don't know her case.
There might be some of that, and we certainly added in when she came for the last transfer. Actually, that's when she came to see me.
There you go.
And so we added the acupuncture piece to help.
So we'll call it seed, soil, and water. You'll be the one.
Yes. So, and that's a great point.
You'll be the sunshine.
Oh, so nice. Okay, come over and get some sunshine.
Yeah, exactly.
And but that's a great point, because at the end of the day, what you're saying is, you know, no matter what you're testing and no matter what the situation, it's a complex scenario. Every transfer is different. Every IVF cycle is different. And there's so many factors at play. We can never fully define and delineate just one causative factor.
Right. But if I had to do like a PSA out there, it would be like, 1, use logic. I mean, as much as you can, like you can't control everything, and be persistent. So logic sometimes is like positive and try again. And sometimes it's don't try again, right? It depends on the scenario.
Yeah. Oh, for sure. And, you know, do you have the resilience? That's actually key. We can't just rely intellectually. This journey is very difficult. And some people, it's like at some point, it's like, I just got to let this go,
yeah,
you know, or not, depending on how driven they are.
So what are your thoughts on PGT, or has your thought changed since our quick discussion here?
No, I'm like you in terms of, I think it's beneficial for some. And if they only have like 1 or 2 embryos, I'm like, I don't know if it's worth it to test. You know, if you have PCOS and you have a lot of embryos, I'm like, yeah, that would be a great option to test, right? Because instead of going through this big bag of tricks, it's like now you're delineating it to specific ones, and so lower probability of lack of implantation or miscarriage.
Yeah, and you know, sometimes we do like a combination. Like I do have a segment of patients where, you know, we aim to do a fresh transfer. So let the embryologist choose the fastest, most beautiful embryo in the cohort that we see, with the thought that that should correlate with our best chance of success, although it's not perfect. Put it in, let's pray, and all the surplus embryos, test them. So hopefully you're pregnant, and then you find out if you really have frozen embryos or not.
But you're not going to do that with a person with PCOS, though, right? I mean, if they're like OHS, hyperstimulating, their environment is likely not, because, you know, you're the endometrial guy too, how I see it. I'm like, is that really
I should have prefaced that if fresh transfer is applicable,
right,
then
Depending on the scenario. See, it's always, it
Yeah,
depends.
we can say whatever we want as long as we say depending on the scenario.
Well, I love this because you know what? Chinese medicine is all about, like, there's never a straight answer. It's always, it depends. Mary, what do you think of this? It depends.
It depends, but as long as it's based on logic, in my opinion.
Yeah. Yeah, there's definitely logic to it as well. So I really want to thank you for adding to this conversation. I think it's so important, and it does, you know, because patients literally come in every day asking this, should I test? Should I not test?
Right.
And then I guess one last question about this in terms of, you know, people don't have so many, and they, you know, that in the past, let's say their experiences, their antral follicle count is low and they're going to do an IVF. And if you have one, or actually, if they just say, or if you know that they're going to have a lower yield, do you automatically say, oh, let's do multiple retrievals and then let's bank and test genetically?
Yeah, that's a, okay, so here's my thoughts on the, what we call serial embryo banking. Okay,
Yes.
so there's different ways to do it. There is make embryos, biopsy, and freeze them, but don't send it off yet. Next round, make embryos, biopsy, but don't send it off yet. Next round, or pick your number of rounds. And at some point we say, okay, send everything. By definition, of course, you're going to have a higher success rate. You just tried 3 times, right? The counter argument is like, maybe you didn't need to try the second or third time. Maybe that first time would have yielded success. So you did unnecessary extra treatment. The reason some people consider this is mostly for cost saving. So if IVF number 1 is X dollars and X dollars and X dollars, it's not like you're paying 3X. You're hopefully paying less than 3X. That's the whole point. Yes. Otherwise, you could just do PGT-A, see if you succeeded. If yes, you're done. If not, try again. If not, try again. So the whole point of banking embryos is hopefully in a cost-effective way, which is important to get you to the finish line. Some people will freeze them at fertilization, so day 1, and say, okay, we're frozen on day 1, go to your next cycle. Frozen on day 1, go to your next cycle. And then when they're all on day 1, they thaw them all together and then biopsy me all together. Again, all of this is a cost, the idea is a cost-saving approach. So 1 day of biopsies and 1 analysis, rather than each time having a biopsy fee and analysis, each time having a biopsy and analysis.
So that's interesting because
there's
to
nothing
me,
magical. There isn't anything magical with embryo banking other than you get to try again.
Yes, of course, of course. I didn't know the whole day one though.
So that's just some clinics. It depends on your clinic how they do it.
But okay, so then let's just speak to this before we go, because you know people are losing their attention span. If you're gonna freeze at day 1 and then thaw and then biopsy and then freeze again, wouldn't that impact them?
So sorry. So you thaw them all on day. Some clinics will thaw them all on day 1. Oh, you're saying, yeah. So double.
So then you're freezing and then you're thawing and then you're freezing again.
Yeah. I mean, that's why not a lot of people do it, but that's one consideration for sure.
Or then actually, let's address this. So some people will have an embryo that has been untested at a blastocyst and then go back and then thaw it out, biopsy, and then retest.
Right.
What do you think of that?
Well, I see that scenario commonly in the following situation. So you do IVF, let's say first transfer doesn't work. Let's say second transfer works, but it's, God forbid, it's a miscarriage, and you test it and you find out. So I like to test a lot of miscarriages because I think it's informative and helps guide us, but I'm not sure everybody does. But let's say they found out the miscarriage was of a chromosomal. So their mindset has totally changed and said, I'm not putting any embryo in because it cannot work. It could be a miscarriage. Why did I not test it? Thaw everything and test it. So that's a very common scenario I see. And of course I work with them and we go through the pros and cons. It's not an unreasonable plan. You know.
So what are the pros and cons of that? Thawing? Okay, so you've frozen.
It's the same pros and cons. So hopefully like it helps you with efficiency. If you have 4 embryos left and none of them are normal, you get to find out. But there's now an extra cost because now you have to do PGT-A, and there's an extra potential harm of the thaw and refreeze.
That's what I'm getting to.
It's a small increment, but it's not nothing. And all these little small increments could add up.
Yeah. So I'm always weary, to be honest, like, and that's just through my own thinking. It's not clinically proven, but it just doesn't jive with me as well when you freeze it and then you thaw it and then you refreeze.
Right. So generally, that's what we counsel before. If you want to do PGT-A, it should be done as these embryos go along, but scenarios happen, right?
Yeah, of course.
But one thing I've noticed consistently is everybody's thought or advice on fertility from a patient's perspective is obviously shaped by their experience. So
Yes.
if you did PGT-A and you have normal embryos that didn't work, you can bet that patient's telling everyone that PGT-A is useless. If anything, it's false advertising. It just costs money. It doesn't guarantee you anything. If you talk to someone who doesn't do PGT-A, has a miscarriage and didn't test them, let's say, they're telling everyone you would be foolish to ever go through this without testing. So your experience really, because you're a sample of one, where we get to read studies and it's samples of hundreds, so we can see the trends. But again, this is why fertility is so emotional. It's a real connection between you and your doctor.
Absolutely. Yeah. And at the end of the day, yes, of course, you're still doing it clinically and through looking at the research, but it's still an individual is an individual. So sometimes you just don't know exactly.
Yeah.
Right?
Yeah, for sure.
Any last words of wisdom as people are going through this?
I don't know, but all I'm thinking is I wish I had your nice microphone. That's what I'm going to get. Any words of wisdom? I think I sort of tried to spread it throughout, but basically, I think you need to be logical, and I think you need to do whatever it is for you that will get you to persistence. If that's financially saving up or getting a bundling, if that's going to see Mary to, put you in a good mental place and be resilient, like persistent and logic are two important variables.
So thank you for adding this in. So people are like looking strictly at chromosomal testing, really what we want to do, because, even clinics now, they say, oh, you should be taking CoQ10, PQQ, right? So, and I would be speaking to, okay, there might be Chinese medicine, there acupuncture, and doing those things consistently over time might potentially increase the health of the eggs as we oxygenate and increase cellular energy. That is a possibility. So looking beyond just the testing and the bigger picture of all the things that you can, myriad of things that you can do, right?
But again, testing doesn't change the actual embryo, whereas intervention might.
Yes, very good point. Exactly. So this is what we're talking about. So thank you for that. And let's have you back. And I would love to talk to you about what you're doing now. And in fact, we didn't even formally introduce you again. This is your second time being here. So as we close off, I'm going to tell everybody who you are if they haven't met you before, right?
You could just edit the video. You could put it in the front.
It's okay. We go with the flow, right? Because you're a fertility specialist. That's obvious. You're in Toronto, but not in Toronto very soon. Am I allowed to say this?
Yeah.
Right. So you're going to be in RCC in Mississauga. You're part of Fertility Partners, but you're also, let's see, look at this. You had complementary training in mathematics. So that makes you like a total numbers guy. So that's why I can see how you love AI, right? Logic, of course.
It makes me boring.
No. So, and you did clinical epidemiology at Harvard University to innovative reproductive medicine through research, entrepreneurship. You're the co-founder of Future Fertility, a med tech startup that applies AI, meaning artificial intelligence, to the IVF lab. So that is so cool. And, there are other clinics that are using your technologies currently, right?
That's right. Yeah.
So you're the co-founder of Halo Health, Canada's first physician angel network. And as I mentioned, you are a medical director at Fertility Partners. So for those of you who want to see Dr. Nayat, he used to be at Trio, and then all of a sudden it's like, oh my gosh, he's disappeared. Where the heck did he go? Well, here he is.
I've been working on this podcast here.
Yeah. But are you already available to see patients?
It's funny. I'm going to be starting my first clinical day on Monday.
Okay, there you go.
Yeah.
And so if you're like, as much as I would say, gosh, you guys in Toronto, maybe see Dr. Dan Nayat, I'm not sure. Again, it's your choice. Pardon me?
It's not that far. It's just the 401.
Where is it exactly?
It's in Mississauga. So it's
where?
401 and Mississauga Road.
Oh, Mississauga Road. Oh, okay. Fine. There you have it, guys. If you
Yeah.
want to reach Dr. Daniel, where do we find you? Email or?
Yeah, there's I created sort of a landing page in the in-between shift, so it's www.drnayat.ca. It's just a landing
Okay.
page for now. Yeah.
Okay, awesome. Thank
Yeah.
you so much for
Mary,
being
thank you.
here.
It's always a pleasure. Thanks so much.
Always. Yeah, and we'll do it again.
Okay, take care.
Take care. Bye.